We'll continue today with a little bit of a discussion about the macro. And for the exam, I will emphasize today on the fact that the macroscopic station, it involves a lot of imagination, and unless if you are able to imagine what's coming next, it will be nearly impossible. These are type of questions that you may get asked, the very common things that we come across in our day-to-day practice, but also they are common to be asked in the exam in these particular stations, and you need to be able to answer. So usually you will get like 2 or 3 questions on the specimen written on the form. And for those who has sitting the exam for the first time, as I mentioned last time, you get 20 minutes with 2 pictures, another 20 minutes with another 2 pictures, and you go to discuss the 4 cases inside a station for approximately 20 minutes. But on every picture that you will have, you get pen, which you can draw on with 4 or 5 colors, and you also will tend to get questions. Now, the problem here that if you don't answer the questions, sometimes the examiner will not ask you the specific question. So in your booklet, when you have your booklets with the picture before you enter into the station, you need to clearly write the questions and your answers for it. Because, for example, if one of the questions, what are the main prognostic parameters for tumors in this area, and you did not answer this question, the examiner will not sometimes stimulate you to answer that question. So you might finish the station and you didn't answer the question, and then you might say, but they didn't ask me. They are not supposed to ask you because they have a marking sheet and you have the question in your hand, and you should have managed your time to answer the certain questions, right? So this is important to keep in mind, because some people sometimes go and make a beautiful station for kata, right? Like you say, I will take this block, I will take that block, and I will take this block, but you forgot to answer the second question, which was in the question paper. How do you grade this tumor, right? And then the examiner, after you leave the room, they will say he didn't pay attention to the question. He only answered half, like the block selections and the reasoning for the block selection, but he didn't say how he will grade the tumor or how he will stage this tumor. And therefore, you then you lose half of the mark. Okay, and it's inevitable, because you might, as I said, if you cannot blame the examiner that they didn't ask you. You should enter the station and you should give answers for these things whenever they are there. And I hope that you've listened to me from the last lecture, and now you are sitting and practicing how you will hold the picture and how you will face the examiner, keep an eye contact with them, both of them, and how you will be able at the same time to point for your drawing on the paper in order to show them how you will deal with this. Of course, the case today is about larynx, and this you don't tend to get the front and the back of the specimen in the same exam. You will only, for the larynx, we tend to give you either the front or either the back, okay? To just make it a little bit more difficult for you. And believe me, there were people who will struggle with this, you see, because they will struggle to define what is really anterior for this specimen and what's posterior, especially under the heat, under the tension of the exam. People tend to lose their concentration. And then I know of people who has failed the FRCPath because they couldn't say what is right from left and what's anterior from posterior. And this is disaster. You see, like you fail in the first moment of the exam, as I clearly have highlighted this last time. So this is what you need to avoid. So even if the specimen looks shocking to you and you don't really know, right? So just try to use a common sense, try to make your best effort in order, I wouldn't say your best guess, but your best effort in order to be able to define what is really anterior and what is posterior. Okay, now if I ask you to describe the specimen, which will be usually the first specimen, then ideally you should be able to tell me what are the structures involved into this specimen, and try to define some of the landmark. So if I, for example, give you a kidney tumor with an nephrectomy specimen, you would expect to define where the ureter, where the renal pelvis, where is the medulla and the cortex, where the tumor, and where is the upper, middle, and lower pole. You see where the adrenal glands, where is the perinephric fat. So these are, for example, an anatomic renal vein, for example, yes. So these are anatomical landmarks that you need to be able to be aware in order to explain for us the specimen in a great depth and a great details. Now, if, for example, I am dealing with this specimen, then I would like to say this is a laryngopharyngectomy specimen, and we will come to the area of pharyngectomy in a minute, so you will be able to understand why did I mention this word, for example, especially if you have never dealt with a specimen like this before. And for example, here you can define that this is the epiglottis, and the epiglottis always have to be anterior into the specimen. So this is really your anatomical landmark to define what is anterior from posterior, and this will ease off most of the confusion that you might, of course, have into into this specimen. So I know it is a simple and common sense, but believe me, it's like a life-saving sentence for this type of specimen when they come. You get, of course, here at these areas which usually connect between the base of the epiglottis and into the arytenoid cartilages, which will be somewhere into those areas. You will tend to have two arytenoid cartilage sitting on top of the thyroid cartilage. And these arytenoids will be sitting somewhere here, and they connect a fold of tissue between the epiglottis and between the arytenoid. We call it the aryepiglottic folds. And there are two of them, of course, one on the right and one on the left. And these are the areas which you really need to be able to address. So let me just annotate this a little bit so you can understand this area here and this area there. So this is some of the landmark that you should be able to highlight into your examiners, and just tell them that the arytenoid cartilage are somewhere here, somewhere there, and that's absolutely fine if you are able to do something like that. Okay, so this is what you will do this, and then you get, of course, the perilaryngeal tissue and the peripharyngeal tissue on either sides, and then you have here, which is the other landmark. I will just would like to show it to you in a little bit of a greater depth. This, what I'm drawing around now, that is the pharynx, okay? And in front of it here is your basically your larynx, and over there somewhere here is your arytenoid cartilages, which will join this epiglottic fold together. So here is your pharynx, and this is why in this particular case, then this is a laryngopharyngectomy, because we have the pharynx posterior and you have the larynx anterior to the pharynx. And this is our posterior surface. And then from the front view, you will tend to have lower down at somewhere at that level here, you will have your thyroid glands, and then you have your strap muscles somewhere there. And then you have this area, which is another anatomical landmark for it, which basically is the base of the tongue. Okay, so providing that you know this anatomical landmark, you should be okay. And this and let me just clear this drawing a little bit. And here around this area there, this box that I'm drawing around it, that's your hyoid bone here, which will go into this area here. Sorry, that's over there into this area. Where is your hyoid bone? Of course, you palpate it, and then you will feel exactly where it is. Okay, so this is where your hyoid bone. So these are your anatomical landmark, and then of course in the front surface here you have your thyroid cartilage, and then underneath it you have the complete cartilage, which is the cricoid cartilage, which will be sitting somewhere around or below the thyroid cartilage. So let's point into those again. So this is how I will present this specimen when I deal with it, right? So I would say, if I am giving that view, I would say this is a laryngopharyngectomy. We can see the epiglottis in the caudal end. This is the lateral wall of the pharynx, and this is the posterior wall of the pharynx. This is the pharynx, and I can see the tumor just occupying most of the pharyngeal aspects here. In front here, we have the two epiglottic folds, and you can see the laryngeal opening. So that will be the supralaryngeal portions, and below will be the glottic, or the supraglottic portion, I mean, and then below it will be the glottic portion. At the lower part, we can see part of the trachea, which is included here into the lower end of this specimen. Okay, so providing that you say these things, then you are okay, and then you will be able to deal with this specimen in a good and common format. If you are giving the anterior view, you would say this is again the epiglottis, the base of the tongue, and then the hyoid bone, and then the strap muscles, and then we have, of course, the thyroid cartilage, the arytenoid cartilage, and the rest of the strap muscles here, and then lower part of the, or the upper part of the trachea involved in the lower part of the specimen. And then we have, of course, the lateral or the paralaryngeal soft tissue on either side. So this is how we should define the structures. And then you start measuring, right? So some people, the problem here in the FRCPath is that some people enter the station and they are too frightened, and they say, this is a laryngectomy specimen. It measures X by Y by Z. Okay, the way I'm going to take my blocks is that I am going to identify this tumor. I will take a one block every 1 centimeter in order to be able to as per the data set instruction, and I will assess the maximum dimension of this tumor. I will assess the depths, and I will assess the margins. Okay, you might think, okay, there is nothing wrong in this, but the way that you should say, this is a laryngopharyngectomy specimen, this is the superior part of the specimen and the supraglottic aspect of the larynx. This is the pharyngeal part of this specimen. We don't see what extent it's going to. It might be going to the upper esophagus. And then in front of it, you have the trachea, and which will be in continuity of your larynx. Okay, you have the lateral part of the lateral pharyngeal walls on either side. This is your epiglottic folds, and this is the lateral paralaryngeal and parapharyngeal soft tissue. From the anterior aspect for this specimen, we should see the thyroid gland and the strap muscles. On either sides, usually will be sent with the specimen or separate, are the two neck dissections from right and left. The specimen measure, the larynx measure, and the pharynx measure, and the tumor measures, yes? And then you would say, if the tumor is involving both the larynx or the pharynx, or it only appears to be occupying the anterior wall of the pharyngeal, of the pharynx, and this is how you will allocate the tumor. So this is when you stay composed, and this is when you stay on top of your game, that you identify the structures, you spend the time, you are like a bullet, you show the examiner that you are very well aware of the anatomical orientation of this specimen, and off you go. You are ready to do the cutting for this specimen, and you will be quite safe with it, okay? So now we will come to how you will be then dealing with this specimen. And the thing is that a lot of you think that we normally tends to open the specimen in order to be able to see where is the tumor is exactly. No, we don't, right? And in the UK, we don't tend to open our specimen. We cut it in the same way. If you ever looked into a CT scan of the neck, usually the CT scan from the neck, it's taken from the base of the skull to the supraclavicular areas in the cross-sectional axial views. And this is what we do in our real life cut-up as well. We will cut the larynx from superior to inferior along its entire length, including the larynx and the pharynx. So this is what we do. So if I just for the sake of the exam, then you will get your ruler, of course, to make a nice lines, not and then you will basically keep drawing sections like what I am doing now, and these are how I am going to cut this specimen, and then basically you will number them, and you can say, I'm going to take the tracheal margins. This is my tracheal shape margins from here. And then in every supraglottic block, you assess for the extent of the tumor, but you also assess the circumferential margin circumferentially around both aspects, because you are going through the entire length of your specimen, okay? You assess the entire circumferential margins of your block, because it is basically taken in the TS format. So let me just show you how that looks like in order to have some imagination of how it looks like. So this is again the tumor. These are the strap muscles here. This is your epiglottis, and the base of the tongue will be somewhere here, and that's your hyoid bone over there. Okay, so providing that we okay, of course we ink our specimen into right, left, anterior, and posterior usually. So this is my normal practice. This is the view which you will not be given in the exam, but occasionally, if our tumor, like in this particular case that I have shown you, it is very close to your pharyngeal resection margin, which is just like in this area here. Let me just draw around it as well. This margin here that I am drawing around it now, that's a mucosal margin of the pharynx, okay? So this margin, you can see it is very close to this tumor. So this margin, ideally, I will take a cruciate of it in order to see the relationship to the anterior pharyngeal wall, lateral pharyngeal wall, posterolateral, and the posterior pharyngeal wall, if the tumor is very close, because otherwise you will lose this margin. So sometimes in some particular supraglottic or pharyngeal tumor, you may need to deal with the mucosal margin a little bit in a more delicate way, rather than taking an entire face and examining it. Just if you miss the right plane of where the tumor might be interfacing with your mucosal margin, if you cannot get this interface in the horizontal block, then you cruciate it in order to get that. But that's not important for the exam, but it's important for you to understand the concept, because you don't get that view in the exam. Okay, so basically this is what we do. Okay, so we do cut the entire specimen from top to bottom. Okay, so you have your basically you're going from your larynx and your pharynx, and then you can see, for example, here your tumor was very circumferential around the pharynx, and while in actual fact the larynx itself was okay. When we cut it that way, what I am trying to tell you that it is not difficult to know and to identify where is your tumor, for example, okay? Where is your tumor is because you can see when you get the larynx as a slit-like with the two vocal cord, you kind of like, you know where you are, and you know that, okay, I am probably at the levels of the glottic here, yes? And when you go up, you go to the supraglottic region, and when you go down, the lumen become more circular, and this is when you get into the subglottic regions of the larynx. So therefore, it is not important to open this specimen to know if your tumor is in the glottic area, if it is supraglottic or it is subglottic, because you don't really need that distinction, because as soon as you cut through the entire face of the specimen, you will be able to see where your tumor in relation to in relation to the pharynx, where your tumor in relation to the postcricoid space, which will be just at the back or between the larynx and the pharynx, and which is important for us in the head and neck world. And you can see that it is not difficult to assess margins, because you can assess the entire margins, including the muscle, if it is included. For example, here you have some of the laryngeal, perilaryngeal muscles here, or the strap muscles. So you can see where your tumor in relation to even the soft tissue around this. And then we sample this as mega blocks. Okay, so we can see our tumor circumferentially. We can assess the extension into the larynx here, into the posterior larynx, into the cartilage. You can see the two arytenoid cartilages just on the either sides. And you can see that the tumor has migrated from the pharynx to the postcricoid space to involve the arytenoid cartilage. It is gone to the lateral wall of the larynx, and it is involving now into the tracheal cartilage, and it's even gone around it into full thickness in this area here, nearly into the outer cortex of this cartilage. And you can assess any extension into soft tissue or circumferentially. Why I'm saying this? Because this is a part of imagination, right? That you will have to go back to this specimen and tell me that when I take my sections, I'm assessing the tumor invasion into the pharyngeal wall. I will assess the tumor extension into the larynx and the laryngeal cartilages. I will assess the lateral extent or anterior or posterior extent into soft tissue and muscles, right? So this is what you should say. You should say the reason why I'm taking this is because it will give me a good assessment for the relationship of this tumor to the larynx, to the cartilages of the larynx, to the surrounding soft tissue and strap muscles, and the thyroid glands when you go lower down into the level. So then it is clear in the mind of the examiner, why do you do that? Okay. The other things as well that I would like you always to remember that the reason why I take also this block 4 to assess the maximum depth of my tumor. So you don't only assess the staging to stage this tumor, but you would like also to assess the maximum depths, okay? And you will also take blocks to assess for the other prognostic features that's involved in this tumor, such as the perineal and lymphovascular invasion. You think it's a common sense? It is a common sense when you are doing the case, but it's an exam. So there is nothing here to say this is a common sense. People should just do it automatically. So no, it doesn't happen. Now, when we come to stage this tumor, there is one aspect here that you need to try to remember, that we have a mix of the TNM in this particular area between the pathological staging and the clinical staging, right? So because you can see, for example, that if you have what we call impaired vocal cord mobility, which is a clinical features, this is not a pathological features because we don't assess mobility pathologically, but it is involved in the classification. So will be a good word to say it in the exam, so the examiner knows that you have read it before. You know that the TNM for the larynx, either it is glottic or supraglottic or subglottic. It's a combination of clinical staging and the pathological staging, okay? But from the pathology point of view, you don't really need to remember a lot about if you are going, am I going to remember what's supraglottic, what's glottic, what's subglottic? That's too much, isn't it? That's really too much to try to remember, or even the pharyngeal tumor TNM staging. No, what is important is to be able, if you get asked, how do you stage this tumor, right? So you need to ask, if you don't remember this staging, because you can't, you can't remember all of them, but you need to remember the aspect. The disaster will happen if you say, because you're making it up, okay? You say if the tumor is less than 2 centimeters, then it's PT1. It is 2 to 4 centimeters, then it's PT2. If it's invading into the cartilage, it is PT3. And if it is beyond the larynx, it's PT4. It's common sense, isn't it? But for me, you made it up, okay? And therefore, you can't now score. There is no way I will let you get away with it, okay? So that's never going to happen. And I'm sorry, it's not going to happen that you will tell me that story and will let you get away with it. No, because now you will provoke the examiner to tell you, is it 2 or 3 centimeters? I will ask you. And is it 4 centimeter, or is it, if it is above 5 centimeter, the TNM phase? And then you say, I think you're probably right. I think it is basically 5 centimeter. Gosh, you see how things can go wrong in the exam, okay? Or you might say, I'm not sure. How do I basically say about something like that? I just will go back before I continue into this specimen. You don't need for the exam to know how you know to differentiate between what's supraglottic, glottic, or subglottic, but the true and false vocal cord, which is around when the vocal cord is slit-like, that's from the extent when you see the arytenoid cartilage into the anterior epiglottis. This is where your glottic larynx is. Anything below is glottis, till you reach, of course, the C6, as you know, which is the C6 is the level where you go into the trachea, which doesn't, you start getting a full complete cartilage in the trachea, and you will realize it directly when it is trachea, because you get a full complete cartilage. And then you have, of course, the supraglottis and anything above the supraglottis, supraglottic region. So this is, but you don't really need to focus onto this, because it is very unlikely that you will be asked this question into the exam. Of course, again, what I wanted you to really focus on is to be able to tell me that I am taking a block from the tumor. You need to translate this, okay? Why you are taking blocks? So this form, you normally find it at the end of every data set in the college. Yes, you have a summary form, and to be honest, this is the form that you should read in the night of the macro station. So you should have them all printed, and you make them all as one folder. So you have only one page of every data set. Then in the night before, you just remind yourself, I'm taking blocks to see the histological type of this tumor. Okay, I will take blocks to see to be able to estimate the measurement and of this tumor in terms of maximum dimensions and depths. And I will take blocks to see the deep tissue plane involved, including the paraglottic and the periglottic space. Okay, if you don't understand what's paraglottic and periepiglottic space, you need to go to the anatomy and try to understand what do they mean, because the reason why we take them, because they upstage the tumor. Okay, I am going to take blocks to show the cartilage involvement, to see the maximum extent, because the inner table of the cartilage involvement is different in terms of staging from the outer table or the full thickness cartilage involvement. Okay, and then I am also taking blocks to assess for the mucosal margins and for the soft tissue margins that I have into my specimen, right? So even if we have extra laryngeal spread, we still have to assess the completion of excision on the soft tissue. So this is one of the things that we do, and this is why we do tend to take our block circumferentially, as I have shown you into this tumor. If you go into the classification, you can see that the T3 in this tumor, it has got the inner cortex of the thyroid cartilage, while the PT4 will have the outer cortex of the thyroid cartilage. And these are good things to mention when you are dealing with the laryngeal specimen, because it doesn't only tell the examiner that you know what you are talking about, but you are telling the examiner that I know that the depths of invasion into the cartilage make a big difference between what's PT3 tumor and what's PT4 tumor, which have a lot of effect in terms of the overall prognosis for these patients and how these patients will do in the future. Okay, so all of these are quite important in terms of this parameters, but it is good to say this. You don't need to remember, but you need to know when the TNM has got numbers or when it does not have numbers to be able to follow into that. I just would like to know now if you have any questions at all before we move to our next case. Because I don't want you to panic when you get into the larynx, but just remember this is how it makes. Okay, we have questions. How do we make mucosal margins? Okay, of course, in the supraglottic tumors, like here, if I look into here into this diagram, this is all a mucosal margin. Let me just annotate it again. So this margin that I am drawing around now, you can see that all of this is a mucosal margin, isn't it? Okay, and this mucosal margin that I'm drawing around is important. Yes, so all of these are mucosal margin into that sense. From the anterior aspect of this specimen, you have, of course, the tongue base margin, of course, which will have sometimes covering over an epithelium, which will also be important if this tumor was supraglottic, not if the tumor is glottic or subglottic, because it's a long way to go to the base of the tongue. But if it's a supraglottic tumor, it has got the ability to go to the base of the tongue, and you might have an incomplete resection from that one. Okay, so if the margin is, if the mucosal margin is close and nearby, like here, for example, this margin is very close. This mucosal margin is close. Then I will take a cruciate block into that margins, because if I only take a horizontal block, I might miss this particular point. Yes, it's very easy to miss it, because don't forget, a lot of this cutting happens under the saw, and you might miss when you cut the larynx under the saw, or might destroy these margins completely. So yes, for the delicate margins, I might deal with it perpendicular if I think it is too close. If I think it is miles away, I can definitely include it in my TS section. Then I will rely on assessing the margins when it comes into my perpendicular sections. Don't forget, your tracheal margin is also a mucosal margin. Your esophageal margin, which will be the shave margins, all of these are mucosal margin. So that is the difference. This is what I mean by mucosal margins and by the soft tissue margins. And I hope that this is clear. Any other questions before we move to the next case? Okay, so the way I was just showing you how you describe the specimen and how you take the block. But yes, what I would do in the exam, if I put the scenarios, I would say, this is the larynx, this is the pharynx, this, and identify what is the soft tissue and give measurement, blah, blah, blah. And this is the strap muscles, the soft tissue, neck, if you have any neck dissections or not, okay, and you say yes. what we tend to do, that after we horizontally cut this specimen, we put it in decal for a few days, okay, before we take our block. Yes, it is because majority of the cartilaginous component, because the larynx tumor tends to happen in people above 60-year-old normally. And usually by that time, the laryngeal cartilage will be very calcified. So in actual fact, with your normal tools, you can't cut through the laryngeal cartilages. And even some of the tracheal cartilages as well, by the effect of age, might be also calcified. So what you need to do after we slice it by electric saw into this, this is the UK practice, okay? So we have electric saws specialized for this, and we cut it in that horizontal plane, and then we put it in decal for a few days, okay? And then we take it, and then we sample the blocks where the tumor is. For what I have said, when you take your specimen, when you do your block in the exam, when you do this imaginary line that I have shown you in this particular specimen, and after, of course, we ink it, and after you do this imaginary line that you will draw on your pictures, okay, to show the examiner that this is what you are going to do. It's a good practice to give it numbers, like what I said last time. So you give it numbers, and then you say, these are the block, and for the one that you will, you will say, I will sample this sequential block to see and then you add up why you are doing it. Yes. So you don't say my block are number 1, number 4, number 5, 6, 7, 8. No, you tell me number 1 is my tracheal margin, number 2 is my esophageal margins, my number 3 will to 6 are the block that I'm taking from the tumor. The reason why I'm taking these sequential blocks to see the maximum extent of this tumor, the maximum depth of this tumor, to characterize this tumor, to say the differentiation of it, to see the maximum, to the perineal invasion, to assess for the lymphovascular invasions into the inner aspect of the cartilage or the outer cortex of the cartilage, into the soft tissue, into the other organs involved, including thyroid glands and strap muscles. This is how I will present it to the examiner, okay? So now I am justifying this, yes? And the reason why I'm taking this block, okay, is because of that. Now, no, we don't. We don't take the tumor blocks before we decal it, but because we cut it into a thin slices, 4 millimeter, then there is a difference between if you leave a specimen in decal for 3 or 4 days, or you leave it for 3 or 4 weeks. If you leave the specimen for 3 or 4 weeks, then you don't basically you don't destroy your tumor, and this is why we cut it in the format that I have shown to you into this format. If you look into this block, this is a live block. You can see that we didn't take anything, okay? We didn't take the tumor from the larynx or from the pharynx, and we didn't even take the strap muscles away. You can see that everything was in this specimen was still included in the block, okay? So there is, okay, so this is the reason why I'm showing you these pictures, is to have that imagination, so you know that, okay, we didn't deal with the tumor separately. No, we dealt with the tumor and the cartilage together, okay? We dealt with the tumor and the cartilage together. If you pay attention to the cartilage here, you would see that the cartilage started to have a bone marrow, and it has bone, okay? You don't really have the proper cartilage like like on the contralateral side, so you can see that there is a lot of ossification of this cartilage happen, and even it's forming a bone marrow. And this is what I'm trying to emphasize here, that with your normal ordinary way of cutting, your normal knife will not cut through this laryngeal cartilage. Okay, so I hope that I made these points clear for you. So when this case comes, it's clear. So no, we don't take the tumor out, and we don't deal with it in any other way. It's a UK practice. You stick to it's a UK exam, the UK practice. You don't go in the exam and you say, in my institute, even if your institute is the best in your region, that has nothing to do with us. Okay, for us as a head and neck pathologist and as a college, we expect you to deal with it in the way that we deal with it in our specialist practice. Okay, and during the training, most of our trainees will go to head and neck placement, all of them, and therefore they all know how to cut larynx because they all saw it and they did it themselves. So, but now, if you have never seen a larynx, at least you can talk about it. And you don't get this TS block in the exam, so you don't have to do this, but you need to have that imagination, because if you don't have that imagination of which structure you're dealing with, you assess your tumor against what, it is very difficult to come up with the sensible and meaningful words in the exam. Some people think that I'm taking block from tumor to subtype it, okay? Because SCC, even if you know, okay, I need to type it and subtype it, yes? Because SCC still have to be subtyped. I'm taking sections to see what is the differentiation of this tumor, right? It makes a common sense for you, but to come up with it as a sentence in the 5 minutes that you are allowed for the case, this is when the tricky part is. Can you really come with the right sentence, or you will just take, some people say, I will take a 1 block every 1 centimeter. Seriously? Seriously? Is that, you see, as soon as you say that word, we know, okay, this is the way, this is not, because every specimen is different. And this sentence get taught in courses, and it is not all wrong, the sentence. Of course, there is some sense in it, yes, but it is not really the right sentence to put into the equation, isn't it? Because 1 block every centimeter, it doesn't make sense, you see, and it's just tell the examiner that you know a template and you're trying to come up with the template for everything. Imagine for the 4th station, you come with the same sentence. I'm taking 1 block from the tumor every 1 centimeter. You know, like it just makes me heart broke. You are breaking my heart as an examiner by coming up with this sentence, and you are not telling me, no, I am sampling this to type and subtype the tumor. I'm taking enough blocks to basically see the differentiation of this tumor. I will take blocks to see the maximum, to be able to estimate the size of this tumor and the maximum and the depths of invasion. I'm taking blocks to see the structures involved, including the pharynx, including the larynx, the depths of invasion into the cartilage, depths of invasion into soft tissue around the larynx, to assess the epiglottic and periglottic spaces, all of these things, you know, all of this vocabulary that you know, but you don't try to come up with. You need to practice on how I'm going to come up with this answer on this view you see on this view, no, you submit the blocks with the tumor. Okay, so the blocks which has the tumor, and you need, of course, to submit a block to show the extent to the supraglottic, so you can, because it upstage. If it's involving more than one region, it will upstage. So you need mega blocks to show the extent to the supraglottic. You need a block to show the extent to the subglottic. You need a or you need a blocks to show the glottic. You need blocks to show the maximum depths and the closest circumferential margins. So these are, so normally what I will do to avoid thinking too much is to take the sequential tumors and sample it in order. Every time I see a tumor, I sample it because it can give me some more information. But if you are so efficient and you don't want, then at least answer the questions. You see, like, yes, you need to show an evidence of subglottic involvement, because what if you go back and then people say, the radiologists say, no, the tumor was only in the supraglottic. Why you are saying the tumor in the subglottic? Because I saw it. No, you need to show me an evidence. Okay, that evidence is a slide. All right, so this is why when we use it, okay? So mega blocks are used for all our laryngeal because we need to keep the anatomy. And if you don't have, then the block can be divided into 4. It is not a big deal, okay? So you divide it into 4 quadrants, like what I'm showing now in the diagram. And this is how you number your block, okay? So you have 1, 2, 3, 4, but with the color differentiation around it, you will know exactly where you are. And are you right? Are you left? Are you anterior? Are you posterior? You will know, okay? So that is not a big deal, okay? So this is just only for the day-to-day practice. But for the exam, as I said, they won't give you this diagram. You only get the actual specimen, and you have to think of it into that parameters, okay? So I think we will move now to my next case, because we don't have a lot of time to deal with it. Let me just clear the drawing. And the next case is a quick one, okay? That is the one that everyone doesn't study for the FRCPath, yes, because you say, what is the big deal of it? Okay, I know what to do, I know what to say, and then it's just chop, block from the tumors every 1 centimeter, and then off you go. Okay, this is how people would say. Of course, we have a data set hasn't been updated for more than 10 years. That probably tells you that there aren't a lot of things happening into the data set over this period of time, okay? So this is, but it is, I think it is in the process of being updated. Of course, when you get the specimen like this, one of the things is that the questions that we tend to say in the adrenal gland, what do you think this tumor is? Which one do you think it is? Okay. So the problem here that, of course, in a tumor like that, these are both an adrenal tumor. These are not kidney tumors. So for those who think that might be an upper pole of a kidney, it is not. These are both adrenal tumor. One of the specimen has got the spleen, and one of them has got the kidney. And this one has got ureter, of course, and this has got kidney. And then we have that structures here, okay? So the problem here, I am not going to give you a specimen that's labeled during the exam, okay? So if you have not seen a specimen like this before, then you are in trouble, okay? Because the focus point of this particular specimen is not the kidney, right? And it's not the ureter. I know that you can define the ureter, and I know that you can define the kidney, and I can see that you are able to see the tumor here. But here is your vein and your inferior vena cava. And this is the problem now, that if you cannot realize that there is a segment of the inferior vena cava now has been removed with this specimen, because you've never seen this before, and you don't know that this is a tumor deposits into this, which is like a tumor embolus, and that is a disaster. This is a recipe for a disaster into this exam. Equally, if you're not familiar that this is a spleen and you cannot recognize these structures as a spleen, then you are still in a deep trouble. Then you have to now think how I'm going to save money again in order to do the next setting. Okay, this is what comes into your mind after you come out of the station. Yes, you will be completely devastated and you think your money is gone now. Okay, simply because you didn't appreciate that there was the vessels and the inferior vena cava vessels was included into this specimen, and this is where you're running into troubles. You're basically, it's a recipe for a disaster, as I say. I just wanted to highlight the anatomical structures. So for the adrenal glands, yes, you need to take margins, and these margins always include vascular margins, which like the renal things, yes, because we have the adrenal vein, which will go into the renal vein. So you need to tell the examiner that, right? So you have the two margins. You might have clips around what has been called as adrenal veins and what has been called as a renal vein. So you need to identify those. And because this will have a huge implication in the staging. And of course, you will take, of course, the normal ureteric margins, and then you will take serial slices from this tumor from top to bottom, and you will take sections into the interface. So if I am to draw around it for my examiner, then I can basically draw with my ruler. Remember, you have to take a ruler, just to show them that this is how you will deal with it. You will have to change directions into that sense. And then you also, for the adrenal gland, just add something, yes? Like add boxes. Let me just show you how I will do this drawing as well. I'm just basically showing you different types of drawing that you will have to do in the exam because it makes a difference. Then you have to draw sections like this, because you have to tell your examiner, I am going to take some blocks to assess for the capsule, which is here, because you want to assess the invasion into the capsule or the invasion of the vessels in the capsule. So all of these are things that you can take. So this is another way of demonstrating this. And I will show you that way in a minute in a better format. If you wanted to show the interface, as I am showing you on that diagram, this is how I will draw it. If the reason why I'm bothered about this, okay? Because the worst scenario, that you go to the exam for the first time, and this is the first minute that you have a pen to draw, and you don't know the directions of your drawing, right? So, for example, you do not know that how I'm going to take my block from the margins, for example. Okay, so if I don't know how I will take a block, for example, from the renal margins, like here, then I would say this is the ureteric margin that I'm going to take, okay, and might look like this, for example. Okay, and then I will take some blocks from that interface, okay, and then I will take the vascular margins, and then I will take to show the tumor emblast. I will take some blocks to show the capsule, and I will take some blocks from my tumor, and I will take another block from every 1 centimeter. Maybe I might do that. Look, how can you number those? What is that? Is that how you're going to enter the exam, with all these lines that I have just drawn in that minute? Because I never drawn before, and I don't know how to make lines. This is a common thing. And then you don't have time to correct this. And imagine that you are showing the examiners your lines. It doesn't make sense, isn't it? And you even cannot point to them because they are all over the place. They're all over the place, yes? So you don't do that, right? You don't just do that, right? So basically you do not do that, but you will have to practice on how you will draw, when you will draw, as I said a minute ago, when I will draw, for example, a straight line. Yes, when I'm going to make that straight line, when I'm going to draw this type of lines, yes, and what I'm going to say about them, right? When I'm going to draw my boxes, yes, and then providing that you know how to do this and you practiced on it, then you look at the drawing, it looks nice, neat, and then you can even remember what you've drawn into this. So you are not going to struggle into what you have drawn into this. So that is one trick I would like to tell you about this adrenal gland. It is not uncommon in the adrenal gland. Sometimes you might get a transverse slices, and one thing to remember of the adrenal gland, that we do not strip the fats around it, okay? We ink it, but we don't strip it out, because we need to see if the tumor has gone into fat and how is our resection margins from the fat is, because you need to be able to assess the R0 or R1 resection, which is a huge, it is kind of like the uttermost important prognostic factors after such a radical operation, right? And a lot of adrenalectomy will not be done nowadays with the kidney, because everyone is having a CT, everyone is discovered, even metastatic melanoma or something that goes quite commonly to the adrenal gland, we can discover early, and we will only do adrenalectomy. So you need to be able to address how I am going to deal with the fat. So if I give you that section from the adrenal gland and in the exam, and I tell you that's a section from adrenal gland, then you have to identify that this is the fat, which we usually keep it intact with our specimen and we ink it, because we would like, the entire specimen will be inked, of course, but we ink the fat as well, because we would like to confirm that this is an R1 resections or an R0 resections, which make a huge implications in terms of prognosis. If I am giving a sections like this, then majority of my block will be, and sometimes you get a breast resections like a wide local excision or a mastectomy, that you tend to be getting a TS section like this from the specimen, then majority of my block will be in the box format. Okay, so you will draw boxes. You don't need too many. Okay, you just say you identify why you are taking the block. Okay, so I'm taking blocks from the interface with the fat to see the extent into the fat, but also to assess the margins of my fat. So the entire circumferential margins of the fat will be examined. I am also will take some blocks to assess for the capsules and the vessels inside the capsule. Ideally, macroscopically, we should comment. So if you are to describe this, you will say the entire adrenal gland in that sections measure X by Y. I will measure it in the third dimension when I see it. Ideally, before I slide the specimen, I will ink it and leave it to fix for 24, 48 hours. Yeah, you can always say that, but doesn't add up into points. But it's give you some time to think and get confidence. But you should say, I see the tumor is probably involving the fat into that corner here. I will show you that in a minute. Here, even if you think it might, or you're not sure, just say, I think. Yes, I think there might be an extra glandular extent into the surrounding fat tissue into this area, and you can draw something around this to remind yourself. So this is an area where you will block. Grossly, I will examine my specimen and look into this specimen. I see some of the blood vessels into the capsule. These are some of the adrenal vein tributaries, and I don't see a tumor thrombi or within these vessels. It looks patent, but I will be examining the capsule for tumor breaches and for assess the vascularity into this. And then I will assess my tumor. If it is a small tumor, 3 centimeters or less, I might sample the entire tumor. If it's larger, I might sample every 1 centimeter. You can say that, that's fine, that's acceptable in this organ, but that's not the answer that I have wanted from you only. What I really want from you to tell me is I want you to tell me that you will sample the heterogeneity of this tumor. So if I think that there might be an area of necrosis, I would like to sample this because it's one of our criteria for malignancy. I will also assess the solid component. I will assess if there is any area that looks different within this tumor in general than the background. And this is how you will draw your blocks into a specimen that's presented to you into that sense. Okay, so that is another way of demonstrating it, but you need to tell us. You need to tell us why you are sampling those things into that sense. We don't have a lot of time left, but I will just take another 5 minutes to just cap into this, so it is more clear into your mind. These are the veins venous tributaries around the capsule that we have to assess for any venous involvement. You have to mention that in the FRCPath exam if you are dealing with the adrenal gland. This is a section from this inferior vena cava, and it has shown this tumor thrombus within it. Basically, the reason why, because if you look into the T3 classification, this is when it is like the renal veins, like the renal tumors in a way. It started with measurement and confined to the adrenal glands, but then the measurement becomes any size, and it can involve into the adjacent organs. Okay, but if you pay attention to the adjacent organs, the organs include vessels, and that include the renal vein or the vena cava, and this is where the problems happen. Okay, so this is where our problem happens into this tributary. Now, if we don't have the vena cava, we can only comment on the fact that the renal veins are involved with the tumor, and it's up to the clinical team now to evaluate what is the status of the inferior vena cava. But and we don't have the renal vein, but if we have them included in our specimen and it's coming with the kidney, then we have to pay attention to the renal vein as well as the vena cava. I expect you to say this in the FRCPath exam, because this is, if you miss this, that means that you are not sampling properly. If you only say I'm sampling 1 block every centimeter, then you miss into these parameters. Some of the adrenal tumor are not malignant, okay? They are adrenocortical neoplasm, and you have to assess the heterogeneity of tumor, the capsule of tumor, because, and the renal vessels, because this is how you know it is a cancer or not, okay? Because it might have been taken for adenoma, you don't know, and you don't make that assumption into the equation. The other things also to remember into the adrenal gland, the involvement of the capsule, which is something that we call it a local invasion. It is a PT3 tumor here. That is the local invasion. And then when you go into the kidney, it's proper, you will become like a proper invasion into your tumor. So these are things to remember. The word, what do we mean by local invasion? Look at this, local invasion. What does that word mean? Okay, so this is quite important, that yes, you might have spread a little bit into the periadnexal fat, or you just reach into the capsule, but it doesn't have this invasion into the organs or into these blood vessels. Okay, but you might get asked, what do you mean by local invasion? If you don't know that this is a breach of a capsule, then it's a problem, because it's in the TNM, and this is the problem of the adrenal gland. If it's to come in the exam, you might get asked about all sorts of things. Yes, how do you differentiate on this as if it's a cancer or not? What is your criteria? This is like when I put the questions at the beginning, sometimes in some questions you might get asked a very specific questions about a very specific entity. It's in the data set, and we can ask you. We don't use the WIS system, we do use the modified WIS system, and you need to be able, it's not difficult, okay? But it has got a combination of these things, which is vascular, capsular, invasion, and like a capsular invasion here, and it has got a combination of some features that's histological. If you don't know, then how would you know the importance of taking this heterogeneity of the blocks? The reason why you sample different areas of the block, because you wanted to know if you have areas with confluent necrosis, because this will affect the way that you will call it benign or malignant, okay? And you wanted to be able to have different areas of tumor so you can assess for the atypia, clear cell, diffuse architecture, all of these sort of things, and capsular invasion. This is why the entire capsule usually get examined, because capsular invasion will have a strong implication if you are going to call this a benign adrenocortical tumor or a malignant adrenocortical tumor or an aggressive. So if you don't know this, please get to know it before the exam. For the paraganglioma, we use this different system, which is called the PASCO system. So if you don't know it as well, please go and read about it, because this is the way that you have to answer. The reason why I'm taking this block, because of what? In SCC, I told you, you type it, you subtype it, you differentiate it, right? But in the adrenal, your tongue had changed into French, yes? So instead of being an English tongue, you say it is a French tongue now, because I will apply the modified WIS criteria, or I will apply the PASS score, which does include this and this and this and that. and my tumor block has to be representative of various areas of tumor to be assess all of these parameters so I can decide if it is benign or malignant. Again, for example, in a tumor like here in the paraganglioma, you can see the extent into adipose tissue, the capsular invasion, all of these are inside our criteria for the adrenal gland. Sometimes if you get a tumor that looks like this and they ask you what it is, yes, please feel free. This is a paraganglioma. If I ask you, do you think it is benign or malignant? Don't answer that. Okay? So do not answer that. That's the question that will fail you, right? Because you might think, okay, based on this, I think it has been resected in total. I don't see extension around the capsule. So I think it's a benign. No, we don't. Yes, because it's basically a paraganglioma with an adverse features or paraganglioma with a good prognosis, and that's all defined by this criteria that I showed you. So sometimes if you have even this, which is another cystic paraganglioma, they tends to be cystic, and if you get it, yes, you can say, yes, I think it's paraganglioma. If I ask you as an examiner, do you think it's benign or malignant? You don't answer that, right? You don't answer that, right? You say, I need to take enough blocks from this tumor to assess a lot of histological parameters, and I will use the PATH score to decide if this of a bad prognosis or this is an aggressive paraganglioma, which people may define under the benign. If I even give you something like this, you don't sample, you don't say anymore. The other things that I don't want you to forget, when you sample a tumor like here, you always have to say the extra that I keep telling you guys. I will sample any deposit in the soft tissue, and I will sample the lymph nodes. Okay? Always remember the things that are not obvious. So even in the larynx, after you take all your blocks, you say, I will sample the neck the nodes, because usually the neck dissections will be sent separately or with the tumor. I will sample any soft tissue deposit that might come across, okay? It's not uncommon for the adrenal tumors and for the laryngeal tumors to have a soft tissue deposits. So it's something that it's a common sense, or even if you don't, and I say, as an examiner, I ask you, are you going to sample anything more and into this specimen? Yes, I will sample the lymph node and soft tissue deposit that might be included in this. And I will sample the retroperitoneal nodes, which is usually sent separate, okay? Because usually for most of the adrenalectomy specimen, especially if we think it's cancer, we will send the retroperitoneal nodes with it, okay? So you should also mention to me the non-obvious. If you get a scale, and that's my last point of the day, so you know that you can go and do your work or you go, if you get a scale like this, please give me the measurement of this tumor, because it's not difficult. You can say this tumor measure 80 millimeter in width and 60 millimeter in 80 millimeter in length and 60 millimeter in width, and I will measure it on the third dimension after I augment the slides together. Okay, so if you have a scale, use it. If you have a tumor, use it, because I might ask you, can you stage for me this tumor, right? So even if you don't see a capsular invasion as a local invasion, full thickness capsular invasion, or soft tissue invasion, even if you miss this, you can always tell me, okay, based on the size, it's above 5 centimeter, because you can measure it. Then you can tell me it is a PT2 at least, right? So at least you've given me some answers. You didn't say, I'm sorry, I usually refer to the data set when I am going to stage this tumor, It's very difficult for me to remember the data set, and it's not on top of my head now, and I cannot give you the staging. I heard this answer before, right? This is a wrong answer to give. So please don't give this answer. Just give me at least, okay? Tell me at least it is a PT2 at least. Then at least you've done some efforts, right? So you've answered the question, you tick the box, you move on. Okay, you've given some sort of an answer. So I think this is what I wanted to highlight into this tumor. The other things which I just wanted you to remember, there is a nice table to differentiate between what's cortical and medullary tumor. If you get a surgical case, either a long or a short surgical case, you would expect to complete the table. You see, if you get an adrenocortical tumor in the long surgical and you're given some of those, I would expect you in the long surgical to complete for me this table. So if you don't know that table, it's in the data set, go and remember it. Because if you get this either in the short surgical as an adrenocortical tumor or as a long surgical, you won't be given all of this panel. You might be given 3 of them. I expect you to complete the things in order to confirm this diagnosis, because this is what the data set is advising you to do, and you have to stick to it. And remember this last page, it will help you why you're taking the block. Okay, so you can see the lymph nodes here is nearly half of the page, but they were not there. But I expect you still to mention it to me in the FRCPath. I hope you guys find that useful as the macro station, how you draw, how you present. It is not really about how you cut, but it is just about, especially for those who've never been to the exam before, at least you know how to handle this, how to do this, and how you will deal with this in a nice way, representative way, and what you really need to talk. You can see we talked about 2 specimens in more than an hour, but remember, you only have 5 minutes. For God's sake, you only have 5 minutes to present this case. All what I've been saying for an hour, you need to say it in 5 minutes. So you really need to be like a bullet. You don't give the examiner a chance to ask you a question, right? If you answer all the question, right, then you will not be asked a lot of questions in the exam. They might listen to you and say, thank you very much, next. Okay, so sometimes this is how it works. Yes, for the complex head and neck, I will bring some of the specimen in the future in order to show it. So hopefully before the next setting, so at least you have seen and you know how to cut them, and you will be able to be familiar with them in a good way. Thank you. Yes, we will upload this very soon. I think maybe in 10 days time or less, we will upload the last lecture and these lectures to the YouTube, so you will be able to get into this. I won't take much more of your time because I know we ran over by 20 minutes, but thank you very much. And thanks for tuning in, and we will catch up next time. You take care for now. Thank you.